India is facing a diabetes epidemic. Gestational diabetes is a form of diabetes mellitus that affects 1 in 10 pregnant women in India, and yet its serious risks to both mother and child are not widely known. Gestational diabetes mellitus, or GDM, is defined as impaired glucose tolerance with onset or first recognition during pregnancy. Women who are overweight, older, have previously had a large baby, and those who have a family history of diabetes are more at risk. However, many women who are diagnosed with GDM have no obvious risk factors. If undiagnosed or poorly treated, it can lead to significant health risks for the mother and child, including increased risk of developing type 2 diabetes later in life.
The new guidelines of 2018 says that all the pregnant ladies should undergo this one-step test, that is OGCT. By doing this, we pick up all the pregnant ladies who have gestational diabetes at an earlier stage, and then they are followed up with treatment, and automatically the outcome is good, and the maternal and fetal complications are limited to some extent.
Importance of testing.
So all the women should be tested for GDM regardless of their previous history or risk factors. We should do a single step test which consists of giving the patient 75 grams of oral glucose. Postprandial blood sugars are tested, and if the values are more than 140 milligram per deciliter, they consider the patient to be having gestational diabetes mellitus. If the first test is negative, we have to repeat the test during the later part of pregnancy, that is around 24 to 28 weeks of gestation. Testing for GDM is an important element of standard antenatal checkup. It should be prioritized, and the availability of testing should be increased at all the levels of care.
Technology. Health facilities with lab services can use semi-auto analyzer or auto analyzer if results can be made available immediately. All other facilities are recommended to use plasma-calibrated glucometer for same-day diagnosis. It can be difficult for pregnant women to return for results on another day, so results and any necessary advice should be given on the same day. Calibration of the glucometer is recommended using calibration test strips or test solutions. It is vital to have facilities for testing and a constant supply of glucometers, metformin and insulin at all antenatal care settings.
Women with GDM feel anxious and stressed out, and this can be overcome by the moral support and the counseling given by the doctors, staff nurses and their family, and this will help her to sail through her pregnancy successfully.
Once diagnosed with GDM, 2 weeks of dietary advice, also known as medical nutrition therapy, and physical exercise should be prescribed. This involves a carbohydrate-controlled, balanced meal plan, which takes into consideration the patient's medical and dietary history and their BMI.
Women should eat small proportions of healthy diet, and they should exercise or walk or do yoga for at least half an hour a day.
Try to take a moment to discuss the difficulties the woman may have managing her GDM. Identifying an achievable goal related to a single behavioral change is an ideal place to start. This could be a small goal such as walking for 15 minutes every day or filling half the plate with vegetables for lunch and dinner. Taking small steps will build their confidence. Women must not be made to feel guilty if they fail to reach their goal, but should be encouraged to keep trying and stay positive. After around 2 weeks of following a meal and activity plan, a 2-hour postprandial blood sugar test should be carried out. If the level is less than 120 mg per deciliter, the pregnant woman can continue with dietary advice and physical activity only. If the blood sugar levels are equal to or more than 120 mg per deciliter, insulin or metformin should be started. Medical management. Insulin is the first drug of choice and can be started anytime during pregnancy. Insulin dose is based on blood sugar levels. If insulin is required in high doses, plain or sustained release metformin may be added to the treatment. Insulin should be injected into the thigh, upper arm or abdominal wall intradermally. The woman must be trained carefully to inject herself and monitor blood sugar levels at home.
Metformin tablets are usually given during the second trimester of pregnancy. They are usually the hypoglycemic episodes are very rare, and the maternal weight gain is less in patients taking metformin tablets.
Some women suffer side effects whilst taking metformin, although these usually resolve after the first few weeks. Diarrhea, nausea, stomach pain, heartburn, gas, and lactic acidosis. The dose of metformin is 500 mg tablets twice daily, up to a maximum of 2 grams per day. At PHC, a medical officer should initiate treatment and refer pregnant women to a higher center if blood sugar levels are not controlled. During medical management, blood sugar levels should be monitored at least every third day.
The signs and symptoms of hypoglycemia are tremors of the hands, palpitations, sweating, easy fatigability, irritability, headache, and tingling sensations around the mouth and lips.
Following a treatment program for GDM can be challenging. It can be helpful to try and involve other family members so they can support the pregnant woman. Encourage women to bring a family member or friend to appointments. Obstetric care.
Ultrasound scans are very important for a pregnant woman as such, and especially for GDM, these ultrasound scanning are important to rule out the congenital malformations.
Ultrasounds are important to determine the health of the baby. At least 3 should be performed. 1 at 18 to 20 weeks for a fetal anatomical survey, followed by 2 growth scans at 28 to 30 and 34 to 36 weeks, with at least a gap of 3 weeks in between. Labor and delivery.
Women with the GDM can definitely deliver normally if they are early diagnosed, they have taken a proper treatment and proper follow-up with the doctor, and if their weight of the baby is well within the normal limits, they can definitely have a normal delivery. And we advise the patient in each step, and also we tell them about the time and time when to deliver. So we usually prefer to deliver them by 38 to 39 weeks of gestation.
While a vaginal birth is preferred, in cases where the baby is expected to be bigger than 4 kilograms, a cesarean section at 39 weeks is recommended. Pregnant women on medical management should have blood sugar levels monitored during labor. Neonatal care. Breastfeeding is recommended immediately after delivery to avoid the baby becoming hypoglycemic. All infants of mothers with GDM should be checked for hypoglycemia using a glucometer within 1 hour of delivery and continued every 4 hours until 4 stable glucose values are obtained. Capillary blood glucose testing for infants should be conducted via heel puncture and performed by a trained health professional. Post-delivery follow-up. Immediate postpartum care of women with GDM should be similar to women without GDM. Maternal glucose levels usually return to normal after delivery. 6 weeks after the birth, the mother must have a 75-gram OGTT. As women who suffer from gestational diabetes are more likely to suffer from type 2 diabetes later in life, it is important that they attend an annual follow-up screening. Advice about healthy lifestyle and behavior should be given at these checkups.
Gestational diabetes is one of the problems faced by women in India. There are many challenges for testing and treatment of gestational diabetes, but with the right attitude and dedication, we can all work together for a positive outcome of the mother and the child.